Confirmed, these hygiene measures can help protect the baby. Washing your hands before breastfeeding, coughing or sneezing into a tissue and disposing of it immediately. Cleaning and disinfecting surfaces you have touched. Wearing a mask where possible. If a mask is not available, WHO still recommends breastfeeding, as benefits outweigh the potential risk of transmitting the virus.
This is TTT. Live for local.
This is TTT Live. I'm Mahalia Joseph Wharton. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Talk City 91.1 FM, Suite 100.1 FM, Next 99.1 FM, and on Facebook at TTT Live Online. We go now to Senior Corporate Communications Officer at the Ministry of Health, Al Alexander.
Good morning, Trinidad and Tobago, and welcome to another edition of the Ministry of Health's virtual media conference, where we update you on the very latest information on the Ministry's national COVID-19 response. Before we begin, we want to recognize the amazing and continued work being done by all our healthcare workers. And today, on International Nurses Day, we thank all our nurses for their sacrifices and support, especially during this current pandemic. The theme of this year's is Nurses, a voice to lead a vision for future healthcare. We thank you once again. Today in studio, we have Dr. Avery Hines, Technical Director, Epidemiology Division, Ministry of Health, Dr. Erica Wheeler, PAHO WHO Country Representative, and Dr. Abdul Hamid, General Manager, Primary Healthcare Services. I am Al Alexander, Senior Corporate Communications Officer at the Ministry of Health, your moderator for this morning's media conference. We begin with the clinical update and epidemiological update from Dr. Avery Hines.
Thank you, Mr. Alexander. Good morning to Dr. Wheeler, to my colleague Dr. Hamid, to members of the media, members of the viewing and listening public. The clinical update for the day concluded 11th May at 4 p.m. is as follows. At that time, at both public and private facilities, 147,470 tests had been performed, and of those, 13,802 would have returned as positive. Out of those positives, we currently have 4,078 total active cases. And of those 4,078, 3,318 are in home self-isolation, 335 are hospitalized, 77 are in step-down facilities, and there were 348 additional positives recorded yesterday, representing cases that would have been or samples that would have been collected and taken during the 2-day period, the 48-hour period just previous, so the 8th to the 10th of May. As at yesterday, there were 224 deaths, and we extend our condolences to the members of the bereaved families. Also, as at yesterday, we had completed 60,487 vaccinations, or first-dose vaccinations, and 1,179 individuals who had already received their first dose have also received their second dose. And that really corresponds to the set of just over 1,000 healthcare personnel who would have been vaccinated in February. A further breakdown of the statistics, especially the hospital statistics, is as follows. Of the 348 additional individuals who would have tested positive yesterday, these individuals will be processed and assessed for need for admission at the discretion of the CMOH. There have been 32 individuals who have been discharged from public health facilities, and there have been 87 individuals who have recovered within the community. So those recovered community cases refer to people who were previously COVID-19 positive and in self-isolation at home, and then subsequently met those discharge criteria. The additional deaths that would have occurred between yesterday and today, the 9 additional deaths, were among 3 elderly males, 3 elderly females, 1 middle-aged female, all with comorbidities, as well as 1 middle-aged male and a middle-aged female without comorbidities. And the distribution of the patients, the 335 patients in hospital, is as follows. 138 at the Couva Hospital and Multi-Training Facility, with 15 in ICU and 48 in HDU. At the Cora Hospital, 78. At Augustus Long, 41. At the Rima General Hospital, 50. At Scarborough Regional Hospital at Fort King George, 27. And the Scarborough Regional Facility at Signal Hill, 1. At the step-down facilities, the 77 individuals are distributed as follows. Claxton Bay Correctional Facility, 7. UE Davie, 32. Tobago, 18. UTT Valsayn, 20. Now, as we've been keeping you up to date and abreast and on track with the occupancy levels, we would like to provide some additional news, some updates in that domain. We have in the recent past, over the last 24 to 48 hours, included an additional 130 beds in what we are calling additional step-down facilities. We will have a little more detail on how those are operationalized and the criteria for those from Dr. Hamid. And this has brought our overall occupancy down, so that the overall occupancy in the ambulatory setting is now 41%. The ICU setting, 74%, HDU setting, 93%. Now, the decrease in the occupancy is really because of the increase in the total number of beds being counted. We still want to emphasize that as new cases are being diagnosed, these people are ill, they continue to need hospital care, and that this is an interim step, but it's not a be-all and end-all solution to the occupancy concern. So we do want to continue to emphasize the need to reduce the risk of getting ill, so reduce the risk of overburdening the healthcare system. Also, just to reiterate that the data that we collect, the data that we collate, the data that we present, disseminate through this means and via print means as well, is all collected under the Ministry of Health's mandate. And that mandate is to present data that is correct, that is transparent, that is complete. That data is collected, collated, processed, and disseminated by professionals of the highest integrity. And it represents the full and transparent picture of all the data and all the information that we have in the healthcare system on a day-to-day basis. As additional information becomes available, that information is presented in the next update. If we note that there has been a variance in the data that we present, we acknowledge that there is a need for variance, and we correct any errors that may occur, as can happen from time to time. So we would like to encourage the population to continue to rely on the Ministry of Health for the up-to-date, complete, correct, transparent data and updates on a day-to-day basis. With that, I believe I'll turn you back over to Mr. Alexander.
Thank you very much, Dr. Hines. We welcome back Dr. Wheeler to the COVID-19 Media Update. Dr. Wheeler will explain the term Emergency Use Listing, EUL, and which COVID-19 vaccines currently in circulation have received EUL. Dr. Wheeler.
Good morning, and thank you, Mr. Alexander. Good morning to my colleague, Dr. Hines, Dr. Hamid, and good morning to the listening and viewing public. It's a great opportunity now that we have more vaccines coming onto the market to actually explain what the emergency use listing is that is provided by the World Health Organization. I first want to begin by saying that there is a Global Advisory Committee on Vaccine Safety, which is a group of experts that provide independent guidance on vaccine safety issues of potential importance to WHO. So every vaccine that has been approved to date has been reviewed by this Global Advisory Committee on Vaccine Safety. Now, there's also a WHO COVID-19 subcommittee of the Global Advisory Committee on Vaccine Safety, which is established to assess the latest safety data for COVID-19 vaccines during weekly meetings. And WHO works very closely with national authorities to ensure that global norms and standards are developed and implemented to assess the quality, safety, and efficacy of vaccines. So when we speak about EUL, as it's known, or Emergency Use Listing, and pre-qualification, this is what it means. Only vaccines that have undergone what's called phase 2 and phase 3 clinical trials. These are the phases before a vaccine is approved. If it reaches a phase 3, it means, therefore, that it is close to being, the trials are close to being completed. And all of this information from the phase 2 and phase 3 clinical trials are submitted to the national regulatory authority of the country. For example, in the US, the CDC. In Europe, you have the European Medicines Agency, and you also have a similar regulatory authority in the UK and in Canada and other countries of the world. But this is what is meant by it's submitted to the National Regulatory Authority, and it is only after this is done it can even be considered by WHO. As data at the moment of submission is not always complete, there's what's called a rolling review. So the clinical trials are still going on and data will still be provided in as part of the dossier from the country until all of the data has been complete. So WHO continues to do an assessment until this dossier is complete. And this dossier needs to follow the format of something called the International Council for Harmonization of Technical Requirements for Pharmaceuticals for Human Use. So there's a common technical document that is used by countries all over the world who are reviewing the eligibility for vaccines. And this is indicated in the document for emergency use listing and pre-qualification procedures. So through the Department of Regulation and Pre-Qualification on the acceptability and principle of the vaccines, these are considered by UN agencies, and this is known as the vaccine pre-qualification. But this is separate, it is a part of but separate from the emergency use listing, and pre-qualification is provided in order to make available all medical products, including vaccines, which are needed in a public health emergency. So this is done, of course, to assist countries to procure for procurement, example, through the PAHO revolving fund for vaccines and through UNICEF. So it is quite a lengthy and meticulous procedure, and all manufacturers are visited by WHO teams and clinical experts to review the quality, safety, and efficacy of the vaccines that are being provided. So a vaccine is approved after the efficacy and safety data is reviewed from what's called controlled randomized trials, which means that you have one group of people that are placed in what's called a control group, which means they are not given the vaccine, and another group that is given the vaccine. And neither the persons receiving the vaccine nor the researchers know which group is which until later. So it's double blind. And these clinical trials are evaluated in the tens of thousands. So by the time you reach phase 3, you have tens of thousands of persons participating in the trial. And after approval, then the vaccines are used in the real world, so to speak, and not in a clinical laboratory setting by much larger populations. But it is important to say that the research does not finish once the vaccine has actually been approved. There's work that continues. So once the product has been listed for emergency use, the procedure is gone through, it must continue to completion for marketing authorization and be submitted to WHO for pre-qualification so that PAHO Revolving Fund and UNICEF can in fact distribute the vaccines. So the decision for that listing is based on a risk assessment of existing quality, safety, and efficacy information, and will include also a set of information on what is to be done after the vaccine is approved. So in order to secure the public's health, what's known as a pharmacovigilance system is required, which means you have to track whether there are any adverse events from the vaccine that has been approved. So just to finish off then, that after approval, there is monitoring of the vaccine, the intensive analysis of reports of suspected cases of adverse events from patients and healthcare professionals. It's actually compulsory to record those adverse events and send that information both to PAHO and WHO. So countries have active surveillance systems that follow up on that, and there is certainly one in Trinidad and Tobago. And there are safety studies that continue to be conducted by the manufacturers themselves, and research studies to examine the safety of the COVID-19 vaccines when they're used in real life. So you can see, therefore, that this is quite a rigorous process. It is one that has been used for all the vaccines that have been approved to date, starting with Pfizer, and we have Pfizer, Moderna, we have all the vaccines, Sinopharm, that has been the most recent vaccine, AstraZeneca. All of them have gone through exactly the same process. There are no shortcuts. It's the same process that has been followed for approving vaccines in the past and will continue to be used. The reason, as I mentioned, that it receives an emergency use listing is in order for agencies such as PAHO and WHO through pre-qualification to be able to distribute it, and for countries to be assured that all of the quality, safety, and efficacy measures have been met on a global level, starting with the national regulatory authorities that have been approved by WHO for decades now. So I hope that it was a bit long, but I hope that explains very clearly that it is quite a rigorous scientific and clinical process that is followed for the approval of vaccines that receive an emergency use listing. And Trinidad and Tobago has committed to only using vaccines that have received the WHO emergency use listing. Thank you.
And thank you very much, Dr. Wheeler, for that update and ensuring us that the vaccines being used in Trinidad are both safe and effective. With the current uptick in COVID-19 positive cases, the Ministry and the RHAs have had to find ways of providing extra bed space to incoming COVID-19 patients. We are pleased to have Dr. Hamid here today to speak on the conversion of one of the UTT campuses to a step-down facility and its benefits. Dr. Hamid.
Thank you very much, Mr. Alexander, and good morning to my colleagues, Dr. Hines and Dr. Wheeler, and to all my colleagues in the health sector and the NCRHA. So today I will be giving a brief overview of the concept of a step-down facility and what it's supposed to do and how it's supposed to operate within the current COVID climate. First slide. So the University of Trinidad and Tobago campus in Valsine is currently being utilized as a COVID-19 step-down facility in the wake of the current upsurge in the number of COVID-19 positive cases. The government of Trinidad and Tobago continues to keep the health and safety of our citizens in the forefront. However, despite our best efforts, the number of COVID-19 cases continue to rise. The UTT Center has been set up to ease the burden being put on our major COVID-19 hospitals located at Couva, Arima, and Cora, in anticipation of the upsurge in COVID-19 reported cases in the coming weeks. Next slide. So basically, it is supposed to be a relief valve for the major hospitals that are in the current system right now. Next slide. The step-down care facility will provide 40 beds. The NCRHA activated 20 beds on Sunday, May the 9th. These active beds will be allocated to people who have tested positive, recovering from the virus. It is in effect an overflow step-down facility referring to people who have recently been in hospital, treated for COVID-19 but are not yet fit to return home and in need of ongoing monitoring and care. The Ministry of Health and NCRH is very conscious of what the experience is all over the world presently, and as such, we must plan for a worst-case scenario. Next slide. So the UTT facility has two aspects. It's isolation. It's providing temporary beds for people who are stepping down from a more acute hospital care, but not quite ready to return home. The major concern all over the world is that the mortality rate is not just determined by viciousness of the virus, but also the availability or lack thereof of beds and ventilators to treat people, as hospitals become overwhelmed by high volume of infected people. Due to the rapid rise in COVID-19 cases in the last 2 weeks, the NCRHA was able to activate UTT Valsane on Sunday into a step-down facility in less than 8 hours, which included the provision and commission of oxygen, medical equipment, and staffing. And within that 8 hours, we started to receive patients. Similar facilities will be operationalized in Point Fortin. And what is the purpose? So it's capacity building of the healthcare system, including extension of the hospital care. It's aimed at low acuity patients. It's assistant to decompress the COVID-19 parallel healthcare system and to aid major COVID-19 hospitals, Couva Hospital and Multi-Training Facility, Arima General Hospital, and Cora Hospital. It aids in decanting of patients to free up turnover space at major COVID-19 facilities, and it assists patients with home quarantining after being discharged from UTT step-down facility. Medical personnel will also ensure that patients have the proper medical care before being discharged home. It is necessary to activate these facilities as our fourth tier of the parallel healthcare system. Next slide. Human resource coverage, and this is extremely important. So medical personnel, doctors and nurses are there to cover the ratio of the number of patients. Each patient is regularly and continuously monitored by both doctors and nurses throughout the day. There's full senior consultant 24/7 coverage on site. Registered nurses, ENAs, patient care assistants all look after patients, and respiratory and mental health therapists will also be available to patients. Also, on discharge, patients may be given equipment to help with physiotherapy. UTT capacity and resources. Total beds 40, active all 40. This facility includes 40 beds with pure oxygen tanks for each respective beds. 32 patients currently quarantined at the facility, and it's expected to reach 40 patients by midday, with an anticipated 15 discharges to home. There are full medical equipment, including crash carts, medical supplies, point-of-care testing, resuscitation equipment, pharmaceuticals. And also, we have pharmaceutical supplies for patients being discharged with prescription to prevent them having to go to pharmacies. What are these patients being housed there? So, patients who will be discharged from the hospitals with mild to moderate symptoms, oxygen requirements 5 liters per minute. So in concept, this is our oxygen therapy step-down unit. Ambulatory care level 5, which means that the patient can do most things for themselves with minimal input. Minor acuity care level 4. The expected time for each patient is 2 to 3 days. And so far, the total number of patients today is 32. And in effect, the total number of patients discharged from Sunday to now has been 15. So basically, in conclusion, this concept of a step-down facility, it's aiding the hospitals to free up the acute care beds in all of our COVID-19 hospitals and hence build capacity. Currently in Trinidad and Tobago, as of Sunday, there were initially 110 beds, and currently today it's 130 step-down beds. Thank you.
And thank you very much, Dr. Hamid. But before we go to our question and answer segment, I hand you back over to Dr. Hines, who will share some interesting update for us.
Okay, thank you, Mr. Alexander. To tack on to the expansion of what we're calling surge capacity, additional bed capacity, we'd also like to inform the public that the U.S. government has, in fact, donated 2 field hospitals, each of them having a 40-bed capacity, and each of them including the capacity for ICU and HDU. One of these will be deployed at the Couva site and one in the Port of Spain area, the Jean Pierre complex, as needed. So if additional capacity is required, these can be pressed into use, and the plans for the actual deployment of these have been outlined. As additional capacity is required, then those will be operationalized, but they're currently not operational but available. So as we seek to expand surge capacity, the capacity to deal with increasing numbers of patients requiring hospital care, this additional bit of information is being shared in advance of the need to actually utilize those facilities. I now turn it back over to Mr. Alexander.
Thank you very much, Dr. Hines. We now move into our question and answer segment. The media representatives are reminded to begin by stating their name and the name of the media house that you represent before you put forward your 2 questions to our panelists. In order for us to get the most out of this segment and to allow a maximum participation, we request that the questions be no more than 2 per media house in the first instance, and after that, based on the time, we will allow 1 additional questions from media personnel. We now begin with CL Communications.
Good morning, Natalie Singh, Caribbean Lifestyle Communications. I was just wondering, is there an outbreak of the COVID-19 at the Mount Hope Hospital? Can you verify? Then secondly, finding out about the number of deaths as a result of the Brazilian variant. I had put this question in the last press conference, and there was a promise to look at the numbers. Thank you.
Thank you very much. Dr. Hines.
Okay, thank you for the questions. To the best of our knowledge, there is no specific outbreak at any particular institution. Now, we do need to bear in mind that as this virus circulates throughout the entire population, you will find people in various locations, including quite possibly within the hospital system, having been diagnosed as positive. We are aware of the need within the healthcare system to maintain what we call infection prevention and control procedures, and those procedures, the adherence to that IPC procedure helps to protect our healthcare workers within the context of our health facilities. And that has been working so far and continues to work. With respect to the deaths and the diagnosis with regard to the Brazilian variant, that information is still actually being processed. So all of the information on which strain was responsible for the deaths that we've had so far is still being processed by laboratories, and as soon as we do have the update, then we will be able to share that information.
Thank you very much, Dr. Hines, and thank you for your question. We now move to Guardian Media Limited.
Hi, morning everyone. You all hearing me?
Good morning.
Morning everyone, Rashad Khan. I'm just going to go ahead with the question because I'm not hearing you all right? So my first question is to Dr. Hines. Now, I just want to touch a bit on what my colleague there would have raised. What is accounting for so many deaths that we've been seeing within recent times? I think if my maths is correct, for the month of May so far, we would have seen about 55 deaths. And I know you answered the aspect of the P1 variant, but could you just go into a little bit more details about how it is, or what is the procedure for you all testing some of these persons would have passed for the P1 variant? And my second question goes to Dr. Erica Wheeler. Now, some time ago, the Minister of Health, as well as some others from on the panel, would have raised the point that due to our low case numbers, we would have actually been further along the queue for the receipt of vaccines on the global scale. But now that our cases are surging and is one of the countries that people are looking at for surging COVID-19 cases at this time, does that raise our priority to receive vaccines, and will that affect anything with respect to the COVAX shipments?
Okay, thank you for your two questions. With respect to the deaths, as you would note, we've had several thousand diagnosed cases within this same 1 month period, or in fact, within the period of this month. And these cases represent the circulation of virus in the population. We are aware that with the numbers of cases that we have been seeing, this represents widespread circulation in the population and a number of people who are, for one reason or another, either compromised or susceptible, would be exposed, with the consequent possibility that some proportion of those individuals will have fatal outcomes. Now, the question you're asking with regard to whether the P1 variant is responsible or not, that genomic testing procedure does require resources, etc., that need to be available and on hand for all of that testing to be completed. So, as I answered in the previous question, once we do have that available, we will share the information, and that is being seen to as we speak. We're in the process of attempting to provide that information. But the increased number of deaths is really as a result of the increased number of cases. And although we note that we have implemented several measures of increasing levels of stringency, we also want to remind the population that the more stringent of these was actually still only very recently implemented. So the most stringent measures being less than a week old, those of moderate stringency being around just under or just around the 2-week mark. And we also have to bear in mind that each time one of these measures is implemented, there was a little bit of a kickback, a rush to access whichever facility was being closed off at the time, and those too will affect the figures. All of that has to work its way through the system before the numbers start to come down. So again, this emphasizes the need for adherence to the public health measures, the recommendations that we've been making to reduce mobility as much as possible, reduce contact as much as possible, so that the measures that have been implemented have the braking effect that is desired. But just to note that at this point, we still do expect that the numbers may get a little higher before they begin to decrease.
Thank you very much, Dr. Hines. The second question goes to Doc. Yes?
Thank
Dr.
you.
Wheeler.
Thank you, Mr. Khan, for your question. So you were asking if Trinidad and Tobago would be more eligible to receive vaccines now that there's been an increase in numbers. So just to backtrack and explain again that for the COVAX facility, which is the facility through which Trinidad and Tobago has been receiving vaccines thus far, in addition, of course, to the gifts from countries, through the COVAX facility, the idea behind it, and that we are still striving for, is to achieve equity. That's why that 20% of the population of each country being eligible to receive vaccines to end the acute phase of the pandemic is still in place. Unfortunately, yes, it is true, what we have seen is surges in countries because they largely, yes, we have not had very effective globally designated therapeutics. There are lots of things that are being used that have proved some degree of efficacy in terms of medications. We know we have vaccines now, which are not a cure, of course, but the intention is to end the acute phase of the pandemic and to prevent hospitalization and deaths. So one of the figures I want to point out to you when we talk about being eligible to receive more vaccines is that last week, according to the Director General, there were more than 5.4 million cases diagnosed across the world, with 90,000 persons who have died. So this is something that is occurring across the world. It's a global phenomenon, that in a pandemic. So countries are not deemed more eligible because of the higher number of cases and deaths. And what the Director General has always warned is that as people become more relaxed and the cases drop, people tend to forget the public health measures, and we see surges in cases. So there is no direct link between eligibility to receive more vaccines based on the increased number of cases. But the second part of your question is whether it will affect the COVAX facility sending vaccines to Trinidad and Tobago. No, the answer is no, because there was an agreement between the COVAX facility and the government of Trinidad and Tobago to provide a minimum of 20% of the population for with vaccines, and Trinidad and Tobago applied for more than that. So that still stands. There will be no deviation from the commitment that was made by the COVAX facility. What is the case is that as more vaccines are approved, and we now have the 5 vaccines that have been approved, say them again: Pfizer, Moderna, AstraZeneca, Johnson & Johnson, and now Sinopharm. They will continue to be available through the COVAX facility. What is preventing more vaccines from coming? It's because manufacturers themselves have not been supplying the amount of vaccines that they once promised. We see what happened with AstraZeneca in India. Because of the outbreak in India, they've reduced export of vaccines, and we know that there were problems with plants in the US for vaccines as well. So these are the kinds of factors. We're in the 5th month of vaccination in a pandemic, and we have a challenge of supply which will get better as the year goes on. So no, there's no link between equity and eligibility. Everyone has to get their 20% initially, although countries can buy bilaterally. That is not excluded. And yes, Trinidad and Tobago, like other countries who signed up, will continue to receive vaccines through the COVAX facility. Thank you.
And thank you, Dr. Wheeler. We now go to Newsday.
Good morning, Narissa Fraser from the News.
Okay, Narissa, we are not hearing you
at the
moment. Narissa, could you repeat the question? Thank you.
Sure, no problem. Recently, I know Dr. Richards would have said the ICU occupancy in the parallel healthcare system had been decreasing, but it's not because people are being sent to HDO or ward level, it's because so many people there are dying. I wanted to find out what is the current mortality rate specifically in the ICU. And lately, I realized that the numbers of tests being done are also decreasing. So I wanted to know if our current positive case to test ratio or daily positivity rate is at an okay place. Is random testing still being done? We have enough kits? What is going on with that?
Dr. Hines?
Okay, thank you for the questions. With respect to the specific mortality rate in ICU, that isn't data that I have at my disposal currently. That information can be worked out and then provided at a subsequent point. I would like to note, however, that the number of daily tests has actually not been decreasing. What you sometimes see, especially after the weekend period, is that the number of tests that may have been performed in that time span may be lower than at other points in the week, and that is really because there are fewer places that are open and available for testing during the weekend period. So you see sometimes lower numbers on a Monday or earlier on in the week, and then larger numbers as we move through the rest of the working week. Now, with respect to test kits, yes, there's adequate supply of those. Both the daily and the weekly and the monthly positivity runs around the average that we've been speaking about, of between 35 and 40% at this point in time. And again, that indicates that there's a high level of prevalence of the virus circulating within the population, and that there's need for increased care, increased vigilance in adhering to the public health measures so that we can reduce the probability of coming into contact with an ill person. So in reducing our movement, in reducing the gathering within offices by reducing office occupancy, in reducing the unnecessary movement to non-essential retail, in all of those activities, what we hope to do is to reduce the probability of susceptible people coming into contact with ill people, given the fact that there is a high level of circulation of the virus in the population at this point in time. So I hope that answers the two questions.
Thank you very much, Dr. Hines. We now go to IETV.
Hi, good morning, everyone. Bina Mahis from IETV News. Two questions. My first question would go to Dr. Hines. Dr. Hines, does the Ministry of Health have any plans to test persons before they are vaccinated with the COVID-19 vaccine to ensure that there are no complications to follow? And my second question, based on reports of persons dying, whether true or not, despite being administered the first dose of the COVID-19 shot, has the Ministry of Health recorded any such cases? And if so, how many? Thank you.
Okay, so in respect to the first question, no, there is no current plan, neither locally nor globally, to test individuals before vaccines are administered. That's not considered global best practice or necessity at this point in time, and it's certainly not the best use of the testing resource. So the vaccination distribution continues as it has been, where the screening to determine your eligibility and the potential safety of the vaccine is done by that medical questioning by the medical professionals that screen you prior to the administration of your vaccine when you turn up. So the testing of individuals prior to vaccine, not done here, not done globally, but we do screen to ensure that the potential for any adverse effects, that potential is minimized by the screening process. Now, the potential, the possibility for someone to still become infected after having a first dose of vaccination remains. And we have said this in the past, even with full vaccination, that does not absolutely prevent you from becoming infected. So that's still a possibility. What it does is it reduces your risk of having what they call more severe disease. The time frame between becoming vaccinated or being vaccinated and then having the full effect of that immunity is a couple of weeks after the shot. So with the first shot, you have a particular proportion of risk reduction, around 60-something%, 67%, but that doesn't kick in immediately. If you were exposed just prior to having the shot, you will still turn up with disease, with a positive test, and possibly with more severe illness, just on the basis of the fact that you were actually exposed before you were vaccinated. So that does still occur, that can still occur, and we do want to emphasize again the importance of knowing that the vaccination by itself doesn't make you COVID-proof, but it does reduce your risk of severe illness, and it does to some extent reduce the risk of spread, which are the two important things that the vaccine rollout, the vaccine deployment is supposed to do. But the vaccines remain only a part of that overall public health response. The overall public health response beyond vaccination continues to include the sanitization measures, the physical distancing measures, the avoidance of gatherings, the avoidance of getting into close contact with people, especially at this point in time with high circulation. So all of these things do still need to be employed simultaneously to get the best effect out of both the vaccine rollout and the public health measures together. Mr. Alexander.
Thank you very much, Dr. Hines. We now go to AZP News.
Hi, good morning. Priya Bihari, azpnews.com. My two questions are for Dr. Hines. Dr. Hines, firstly, AZP News has a report of a patient who had emergency surgery at the San Fernando General Hospital, and the relatives of the patients had to were asked to get a number of items post-surgery, such as circulation stockings, amoxicillin injections, and things like that. My question is, therefore, do we is there a problem in terms of resources in the public health sector which are being sacrificed for that in the parallel healthcare system? That's my first issue. And my second question has to do with the testing. People saying that while they take their COVID-19 tests, some are waiting up to 5 to 7 days to get results, and they are told to go and self-isolate home. And if they are positive, unfortunately, other members of the household contract the virus, and because they are saying it's very difficult to self-isolate at home. Is the ministry aware of this situation, and is that one of the reasons causing the upsurge? And is there any policy to deal with this situation? Thank you.
Okay, thank you for the two questions. The short answer to your first question is no. The resources in the parallel healthcare system are not cannibalizing those available in the public healthcare system. So that's not the case with respect to whatever has been said about people being asked to collect particular items. The operational aspects of what's available in which facility are, of course, within the domain of the RHAs, so more detailed questions could be directed towards that level of the healthcare system. Now, with respect to the risk of getting infected in the household, we do have, and we have emphasized, and we can take the opportunity again, to re-emphasize the guidelines that we've provided for the reduction of risk of transmission in the household if you're self-isolating, whether or not you know that you're positive. Once you've done a test and you're concerned, these guidelines that include the remaining in one part of the house, wearing your mask in the household, not sharing household items or household spaces, all of this information is actually available on the Ministry of Health website, and we want to refer everybody to that information at this point in time so we can review it, because you are quite correct in assuming that there is an increased risk of transmission in a household where those guidelines aren't followed. But we've also seen the success of those guidelines in preventing household transmission. So once we're in household and we are aware that there is a risk, implementation of all those risk reducing factors is very important. And of course, you can reach out to the healthcare system through the hotline to indicate that your household circumstances may not be suitable for you to do the household isolation in the best possible way, and discussions can be had on how you can be assisted. So we do want to make the appeal again to review those guidelines and to use as much of the recommendation as can be used in your particular setting to reduce household transmission.
Thank you very much. Express, we are ready for your questions.
Good morning, Camille Hunt, Express. Dr. Hines, I wanted to get an idea of the staff to patient ratio, particularly in the ICU and the HDU. Since we've been seeing higher numbers in those units, I'm wondering how many medical staff are there to attend to all these patients? And do we have sufficient antiviral medication to treat these hundreds of COVID positive people?
Okay, thank you for the question. The staff to patient ratio is maintained at the optimum that's recommended by the international best practice within the limits of the human resources that we have. While I cannot, with any degree of specificity, give you ratios from the information in front of me, you can be assured that as the occupancy increases, the staffing is also increased to meet the needs and ensure that optimum care is provided in accordance with international best practice. The second bit of the question, can you just remind me what that second bit was? Antiviral, yes, that was a little confusing. As Dr. Wheeler just mentioned, there isn't any specific antiviral therapy that is utilized for the treatment of COVID-19. There is general supportive care, and there are certain other medications, including certain types of steroids that are utilized, but there isn't specific antiviral medication that is currently in use. But to answer the broader question, yes, the medications that are needed for the care of the patients are available to them in sufficient quantities.
Thank you, Dr. Hines. We quickly move to TV6.
Good morning, Urvashi from TV6. Dr. Hines, can you give us an idea of what the COVID mortality rate would have been prior to this phase, so maybe like February compared to now? Are more people dying at home or at the hospital? And my second question has to do with testing. Now, we note that when we get test results today, it would be for 3 days prior. And I also know, Dr. Hines, that this would have been going way back to March. But of course, in March, within private and public capacity, we were doing about 300 to 400 tests and getting 10 positives. Now we're seeing on a daily basis, when you look at the change in numbers, we're up to like about 6,000 tests and we're getting 300 plus positives. How is this affecting your true daily positive outlook? Thank you.
Okay. So, good questions. The first, the mortality rate overall has actually remained around between 1.5 and 1.7%. In March, that had dropped to about it was around 1.6. And as we got additional positives and additional mortality, it has really hovered between that 1.5 and 1.7% overall. What you referred to next was the positivity, and that's the figure that we refer to when we're doing the epidemiologic update. Out of every 100 tests that we do, what percentage is showing up as positive? What you would have seen in March is that positivity was around 2%. And as we mentioned earlier today, and we've mentioned in the previous epidemiologic updates, it's now around 35 to 37%. So the positivity is what we refer to when we say there's a high level of viral circulation. So if you're looking at outlook from the perspective of risk of becoming ill, then what we are emphasizing is that with this high level of viral circulation, there is increased risk of coming into contact with an ill person. And as a result of that, the importance of the adherence to all the guidelines, the mask wearing, the physical distancing, the reduction of occupancy in offices, the reduction of movement and non-essential activity at this point in time, all of those things will help to improve the outlook by reducing the risk of ill people coming into contact with susceptible people and transmitting the illness. So yes, that positivity does increase that risk, and that's what we're hoping to reduce by the application of all the measures.
Thank you very much, Dr. Hines. We move to I-95.
Good morning to everyone. Whitfield Turner from I-95.5. My first question, Dr. Hines, are you any closer to being able to pinpoint exactly what is driving the current surge in cases that we're seeing? And my second question for Dr. Wheeler, can you confirm whether any of the Cuban vaccines have received WHO approval? And if you have it, can you give us the full listing of vaccines that have?
Thank you very much, Dr. Hines.
Okay, so thank you for the question, Mr. Turner. As we have repeatedly said, when you're in what we call this log phase, this exponential phase of viral transmission, what is driving the transmission, what is driving the spike is ill people coming into contact with well ones and transmitting illness. To the extent that we can reduce that probability, to the extent that we can stop people from coming into contact with each other and transmitting illness, we will have that reduction in the spike. But right now, as with any transmissible disease, during a log phase of an outbreak, it is being driven by the proportion of ill people and the probability of those people passing the illness on to others. Bearing in mind that there's that multiplicative effect where one person can infect not just one other person, but 3 or 4. So that 3 or 4 then each infect another 3 or 4, and you get very large numbers accumulating in a short space of time, because that's how these transmissible illnesses work. That's what that exponential rise really means. So the figures that we see are really as a result of the simple math of epidemics. That's what's driving the increase in the figures. Mr. Alexander?
Thank you very much. Dr. Wheeler? Second question.
So you were asking, thank you for the question, you were asking whether the Cuban vaccine has been approved. Not at this point, and it's because the Cuban vaccine is now, it just recently entered in March into phase 3 of the clinical trials, which is very promising that it has entered into phase 3. There have been vaccines sent to Iran in terms of getting a geographical spread, because this is what is normally done. You have to check for age, geographic spread, gender to be included by the time you get to your tens of thousands in phase 3. So they're still in phase 3, and we await the outcome of the phase 3 clinical trials. You also asked which vaccines have been approved by WHO so far. There are 5: Pfizer, BioNTech, Moderna, AstraZeneca, Johnson & Johnson, and the one most recently approved last Friday was Sinopharm. So those are the vaccines that have received approval. What the good news is, though, that we have reason to be optimistic, because there are as many as 280 vaccines in development, of which 97 are actually in clinical development, meaning they're in some stage of clinical trials. So as the rest of the year goes by, we would see more and more vaccines entering into the COVAX facility if they reach the standards for quality, safety, and efficacy. So we have reason to continue to be more optimistic. Thank you.
And thank you for that response, Dr. Wheeler. We go to Astronaut News.
Gwyneth Stewart, Astronaut Health News. Good morning, everyone. There was a recent report that the CDC is saying that the SARS coronavirus can be airborne. Is that true? And if so, they said that it can travel, the report said that it can travel further than 6 feet from an infectious source, can remain airborne for hours, and can accumulate in an unventilated space. So if this is the case, do our leaders have any plans to increase the designated 6 foot for social distancing? And is the PPE currently provided for healthcare professionals adequate? And also, as a follow-up to my colleague Bina's question, I would like to ask both questions to Dr. Hines. Does the MOH have any statistics on how many of the approximately 3,000 cases which occurred in May were indeed cases that were vaccinated? And can that information be provided if we have these statistics?
Okay, thank you for the 2 questions. With respect to the CDC's announcement, the important thing that we need to emphasize is that the traveling of those airborne particles is also dependent on them being expelled freely from your respiratory tract, so that the mask wearing that has been made mandatory since August of 2020 is one of the factors that's going to help to mitigate the impact of that transmission, of the expulsion of aerosols, even within the context of that airborne transmission route that has now been confirmed as being more significant. Now, you would note that this isn't actually news. This is something that they were verifying how much it contributed to the overall transmission, and they have now confirmed via various studies that it does contribute in a significant way. But the other bit of the information that sometimes isn't circulated is that the accumulation of these infectious droplets, infectious aerosol particles in indoor spaces is drastically reduced by universal and consistent mask wearing within these spaces, and with the reduction of occupancy of those indoor spaces. So that that mitigating factor, that risk reducing factor that's already in place, the emphasis on its importance is now being shown. The emphasis on the need for the mask wearing in the indoor setting, wherever you're going, everyone wearing their mask properly, covering their nose and mouth, is going to help to reduce that risk from what we now know is a more significant pathway for transmission. And with respect to the number of people vaccinated and still getting COVID, there are actually very few of those that have been brought to the attention of the health system. There isn't an official total figure, but the ones that have been seen showing up in the healthcare system are few and far between, and usually occurring relatively soon after that initial vaccination, suggesting that they may have actually been infected just before or just after the actual vaccine event, when the immune response hadn't been optimized yet.
Thank you very much, Dr. Hines. We've come to the end of our question and answer segment. We want to once again wish all our nurses a happy International Nurses Day. You are all our health heroes, and we thank you for the continued sacrifice that you have been making. And once again, thank you for viewing this COVID-19 update. And we remind you to keep the information that we are sharing with you and keep updated using our website and all the information that we continue to share with you. Once again, stay home if you are ill and practice the 3 W's. Wash your hands, watch your distance, and wear a mask over your mouth and nose when in public. Goodbye for now.
Este